Yeah, good morning, everybody. So I'll be having, thank you, Dr. Rohan, for having me here. So I'll be giving two talks. So one is on vascular occlusion and another for retinal peripheral lesions. So let's talk about laser for vascular occlusions. So not much is written about in textbooks about how to laser these, vein occlusions. So no financial interest. So we know when a patient comes with vein occlusion, you cannot reverse the vein occlusion. The vein occlusion won't go. But what the treatment for vein occlusion is for the complications of the vein occlusion, which are macular edema or ischemia, or when the patient presents with RD or vitreous hemorrhage. So when there is macular edema, you can treat with anti-VEGF or a macular laser. When there is ischemia developing NVI, NVD, you do laser. And when there is vitreous hemorrhage or retinal detachment, you do a vitrectomy. So let's look at some cases. So this is case 1, 65-year-old female, hypertension, dyslipidemia, 6/6 vision, superior hemivein occlusion. So no macular edema here, vision is 6/6. So she came to know after coming to us that she is also hypertensive. So got all that evaluated. Now this is follow-up without treatment, follow-up after a month. So this is month 2, vision is still 6/6. This is month 4, all the hemorrhages are slowly resolving, no anti-VEGF, no laser, vision is still 6/6. This is month 6, and now there is something happening. Vision is still 6/6, but on close look, you can see this small reddish patch just above the disc there. And when you look, just zoom into the photograph, you can see this new vessel which is happening above the disc. So this is like 1 DD close to the disc. So I'll say that this is like an NVD. And that's when I do the superior sectoral laser, which I cover 180 degrees of the fundus. And this is 1 month post laser, vision is still 6/6. And post 6 months post laser, vision is 6/6, and the laser is holding pretty well. So here the indication is only when you develop the NVD, then only you need to go in and do your laser. Otherwise, the patient can be observed if the vision is good. So let's look at another case, case 2, 58-year-old female, hypertensive, 6/6 vision here again, but she came with complaints of floaters. And she was found to have an inferior BRVO with vitreous hemorrhage, no macular edema. So this is the NV which is developed over there, and you can also see this is quite old because there are collateral vasculature also which is developed over, and along with that there is NVE also, and which has caused the bleed and the hemorrhage which has come. So now the initial treatment in this patient will be to laser, and then you need to closely follow up. So this is close follow up after the laser, and however 6 months after the laser, there was a vision drop to 6/18. And now when the patient has vitreous hemorrhage, now here the patient was advised vitrectomy. But the first treatment will always be a laser. So let's look at third case. Now this case is just to show you how much to laser, what extent will you laser in these vein occlusions. So the posterior extent to where the ischemia is there, the ischemic vessel is there, and then the laser should go on till the periphery up to the aura. So in these vein occlusions, the ischemia is up till the aura, so you should laser right from the posterior up till the ora serrata. So let's look at another case, case 4, 71-year-old female. She was referred for doing a laser. Again, no complaints in the left eye. She came for right eye cataract surgery. 6/6 vision in the left eye. Again, you can see this ischemic, sclerosed vessels over there. But tried searching for NVD, NVE, there is none of that, and there was no NVI also. But however, she had these collateral vasculature. You can see the collateral vessels which are supplying the ischemic zone from the superior part, and it's supplying to the inferior part. So here again, I did not do the laser because already it was perfused. So month 4 follow-up, 6/6 vision left eye, no NVI, no NVE, no NVD. So here again, I did not do any laser. So these patients can just be closely observed and followed up. So learnings is close follow-up and pan-retinal or sectoral laser in the setting of ischemia only, or when there is NVA, NVI, NVD or NVE, and gonio needs to be done every 3 months along with undilated fundus examination, undilated anterior segment examination to look for NVI also. So now let's look at case 5, 58-year-old male, diabetic hypertension, a 660 vision right eye. So he had an NI CRVO, that is he's got a CRVO also. You can see the hemorrhages on top and below, and then on top of that, he's got a ischemic hemi-CRVO. There is a hemi-CRVO. So he has had 2 occlusions. So there must be a small CRVO which has happened, and on top of that, he's got a hemi-CRVO also which has happened in the inferior quadrant, and he has come with macular edema and those exudates what you see. And there was suspicion of an NVI, and IOP was only 15. So here we went ahead and decided to do anti-VEGF followed by 3 sittings of pan-retinal photocoagulation. So this is after anti-VEGF and 3 sittings of PRP. You can see the extent of the laser. It's almost up to the periphery there. That's how much the laser you have to do, up till almost till the aura. And after this treatment, the vision is 618, and we also did a macular laser because she's already taken multiple anti-VEGFs. So we also have gone and given a grid kind of laser close to the macula there. So let's look at another case. I think the final one, 6-6 vision, 80-year-old male, hypertensive, 636 vision in the right eye. You can see gross macular edema. So he's got a superior branch vein occlusion. And after treatment, this is a wide field photograph. You can see the extension till the periphery. And then after treatment with dexamethasone implant, that is steroid implant with and also a macular grid laser, you can see how posterior you have to do the laser over there. So it almost acts like a macular grid laser. And then he was stable post treatment with vision remaining at 636 because of the chronicity, there was some atrophy at the fovea. So some learnings from these cases. So if it's a BRVO, the outcomes are good with macular laser, and the BRVO study also says that macular laser was the standard of treatment before the advent of anti-VEGFs. So now you can combine treatment with anti-VEGF. After you treat with anti-VEGFs, once the macula is flat, then you can go and do your macular grid laser. But there is no visual benefit in CRVOs when you do a macular laser. So in CRVO, there is no role of macular laser as the edema doesn't resolve with the macular laser. But however, the recent studies shows that if you do it in a young patient, then it's of some benefit, but not significant. So the final case 7, 75-year-old male, neovascular glaucoma due to a CRVO. You can see the new vessels at the iris over there. Now in such a case, if the view is there, then you will go and do your 3 sittings of pan-retinal laser along with an anti-VEGF injection. So I won't go much in the details of NVG because it's a totally different topic. So to conclude, pan-retinal laser is the gold standard for complications of the vein occlusions. And when you can combine laser with anti-VEGF or steroid injection, especially when there is macular edema, follow-up is extremely important even after laser treatment. And macular laser is good in BRVOs, but not so effective in CRVOs. Thank you.